Hello, my name is Ilaria Colombo, and I'm joined today by Professor Christian Marth from Innsbruck University to discuss how can we improve the outcome of patients with advanced recurrent endometrial cancer with the use of immune checkpoint inhibitors. We can start the discussion on this very important topic, and I think we are all excited about the news that we have recently on the use of immune checkpoint inhibitors in endometrial cancer. So, Christian, what do you think are the key challenges that we have in the treatment of endometrial cancer?
Yeah, thank you very much, Ilaria. I think it's a very important point. So for decades in the treatment of advanced or recurrent endometrial cancer, we had endocrine therapy and we had chemotherapy. So most recently, we had this first-line therapy in endometrial carcinoma. We used carboplatin paclitaxel combination, which resulted in an overall response rate of 50% and a progression-free survival of 14 months, overall survival of 37 months. In a recurrent situation, the second-line situation, chemotherapy gave us a very poor outcome. So with an approximately response rate of 10 to 15%. So altogether, chemotherapy is not a good option for those patients, and there's an urgent need to improve. And so we are happy to be today here and to discuss the new possibilities which have been developed recently.
Yeah, thank you very much. I completely agree. And so we have seen recently that immune checkpoint inhibitors have entered first clinical trial and now clinical practice for the treatment of these patients. So can you tell us a bit about which is the mechanism of action of immune checkpoint inhibitors and why they are relevant in this tumor type?
Yes, the cancer cells are able to be protected against the activity of the immune system because they express PD-L1. And this PD-L1 receptor is downregulating the T regulatory cells, inhibiting them to attack the cancer cells. And when we use checkpoint inhibitors, masking these PD-L1 receptor, then the effector cells are able to attack again the cancer cells. And this mechanism is especially effective when the effector cells, the lymphocytes, are able to find antigens which are maybe tumor-associated antigens or foreign antigens, and then this type of treatment is very efficient. So therefore, it's important to understand how these cancer cells are expressing these neoantigens. And we know now that since the results of the Cancer Genome Atlas and many other publications, that mismatch repair deficiency is one of the most important parameters telling us what are tumors which might respond to immune checkpoint inhibitors.
So thank you very much for clarifying this very well. And as you say at the beginning, we have now this new option, and I think this is very important for a patient with endometrial cancer. And can you tell us which are the approved immunotherapy agents that we have available now for the treatment of our patients with endometrial cancer?
Yeah, many phase 2, phase 1, phase 2 trials have been performed, with finally resulted then in also an approval of immune checkpoint inhibitors. So what we understood, and that we have a large experience with the Garnet trial and dostarlimab, and we have also a large experience with the Keynote 158, the pembrolizumab. In both cases, it has been observed that the overall response rate for mismatch repair deficient tumors was approximately 46 and 48%. So there's much more than has been seen ever with other types of treatment in endometrial carcinoma. For the mismatch repair proficient tumor, the overall response rate was significantly lower, with approximately 11 and 15%. for these two agents, which are now available in Europe for the treatment of endometrial carcinoma.
And we have seen, as you explained very well, that immune checkpoint inhibitor alone are less active in tumors that are mismatch repair proficient. So what has been done to try, for example, to increase the activity of this agent in this patient population?
Yes, there has been several approaches. In second line, especially a combination of checkpoint inhibitors with anti-angiogenic agent has been evaluated. The combination of pembrolizumab with lenvatinib in the Keynote 775 trial. And in this combination clearly showed us that in mismatch repair deficient, you have approximately 42% over response rate, which is very similar to what has been seen by single agent. However, in the mismatch repair proficient group, the response rate was increased from 15% to 32%. And this trial also demonstrated in second-line endometrial carcinoma for the first time that the combination of checkpoint inhibitor plus tyrosine kinase inhibitor improved not only the response rate, but also resulted in an overall survival benefit and obviously also in a progression-free survival benefit. So I think that's a major step forward. However, we could also think to look for other combinations, and this was especially also evaluated more in first-line therapy. So can we combine chemotherapy with checkpoint inhibitor therapy? So this approach is interesting because we assume that by chemotherapy, we might result in a release of, again, tumor-associated antigens, and this could increase the efficacy of checkpoint inhibitor therapy. And so, therefore, it was a clear, straightforward clinical trial to look and to evaluate the combination of chemo plus checkpoint inhibitor therapy.
Yeah, and thank you very much, Christian, for mentioning this study. I think this has been one of the most important news this year in the endometrial cancer. We have seen the results of the Ruby trial with dostarlimab and the NRG G18 study with pembrolizumab. Could you please tell me really what you think? What are the most important, take-home message from this study that were presented and published this year?
Yeah, I think that's really amazing what we saw with these trials. So for the first time, we could demonstrate that especially in the mismatch repair deficient group, we saw an amazing increase in progression-free survival. So when we look in the Ruby trial, the combination of carboplatin paclitaxel plus dostarlimab was resulted in a hazard ratio of 0.28 compared to carboplatin paclitaxel only. And what I think it's the most important finding is not only this amazing hazard ratio resulting in a progression-free survival of 15% after 2 years compared to 61%. So this is an increase of almost 50% in the progression-free survival. But more important, after 1 year, there have been no progression events anymore. So the curves are completely plateauing. So for the first time, we might dream that we would be able to increase the cure rate in advanced or recurrent endometrial carcinoma. Very similarly, also the second trial, the NRG-018 trial, also resulted in an improvement in progression-free survival in the mismatch repair deficient group. For the proficient group, also both trials, the NRG-018 and the Ruby trial, both demonstrated an progression-free survival benefit, although the difference was reduced. And here I think it will be necessary to better understand what are the patients who have a response by the addition of checkpoint inhibitor therapy.
Yeah, so thank you very much, and I completely agree with your sentence. Say that really these results are amazing, and if we go back to the beginning of our discussion when you well describe the poor result that we have with chemotherapy in first and in second line, we can really understand how immune checkpoint inhibitor have really changed the treatment paradigm of this tumor. And the last question and last point that I just want to ask to close this interesting session is I think we are just at the beginning of what we are improving or doing in the endometrial cancer, and just a short comment on your few insight in the future. What will be the other data that we are waiting and that may give us further important results?
Yeah, I think this promising results really raise the question: do we really need chemotherapy? So could we avoid chemotherapy by evaluating the checkpoint inhibitor therapy only? And here, two trials are ongoing. Very important: the Domenica trial, the mismatch repair deficient patient. They will be randomized between chemo versus a checkpoint inhibitor, dostarlimab. On the other hand, we might also try to combine checkpoint inhibitor therapy with, again, the tyrosine kinase inhibitor like lenvatinib. And this trial, the LEAP-001 trial, the ENGOT-EN9 trial, will also ask the question, can we in first line avoid chemotherapy to treat those patients chemo-free, also in the mismatch repair proficient case? And the final question, should we move even forward? Should we try to use checkpoint inhibitor therapy in the adjuvant setting? And the last question, obviously, are other combinations interesting? So we all know that the PARP inhibitor might play a role, and the first trials are coming to apply also PARP inhibitor in the treatment of endometrial carcinoma to increase again the efficacy of a checkpoint inhibitor therapy.
So thank you very much. So important data we have now, important results, but a lot of has still to come. So I think one important message for our colleagues and for the patient as well is that the treatment of this tumor is improving, and we need to still be really tuned on the new results that we will be presented soon as well. So thank you very much, Christian, for this lovely discussion and this interesting review of the most important data on immunotherapy in endometrial cancer.
Thank you very, very much, Ilaria. It was a pleasure to discuss with you these really new developments in endometrial carcinoma.